Yeah. So just please let me know, am I audible to everyone? Yes. So good evening, Chandia. Yes, Vinus Bansal. Good evening. Okay. So I welcome you all to another clinical and image-based questions. So this session also, it's going to be very interesting, and the questions which I will be doing today, we definitely can expect at least 2 or 3 questions from the today's session. So what is that I have included in the today's session is I have also included some of the ECGs as well. So ECGs is one of the very important area where the questions can be asked in your exam. Right. So Vinus platform के ऊपर depend होगा. So don't worry about the photo. So just see whether my voice is audible or not. That's all. Right. Okay. So now let us start with the session. And please inform to all of your friends to join the session, because this is completely a free session. And in this session, we will be discussing almost like 10 to 15 clinical and as well as image-based questions parallelly. Okay, right. So let us start with the session. Right. You see the question here. We have a 49-year-old woman has myocardial infarction 7 weeks ago, but is otherwise recovering and feeling well. The electrocardiogram obtained in the office is shown here. An echocardiogram most likely will reveal which of the following. Right, so ECG is given to you. So based on the ECG, you should be able to tell the diagnosis now. Right, based on the ECG finding, you should be able to tell the diagnosis now. So the question is that 49-year-old woman had myocardial infarction 7 weeks ago, but is otherwise recovering and feeling well. The electrocardiogram obtained in the office is shown here. Now, an echocardiogram most likely will reveal which of the following. Large pericardial effusion, biatrial enlargement, calcified pericardium, ventricular aneurysm, new anterolateral wall motion abnormality. So what do you think will be the diagnosis? Okay, so I got the correct answer from Gayaz Mohammed and I got the correct answer from Venkat Kishore. So the answer to this particular question is ventricular aneurysm. The answer to this particular question is ventricular aneurysm. Now, why is that ventricular aneurysm and what will be the features of the ventricular aneurysm? Let me explain. Okay, so the patient had infarction 7 weeks ago. 7 weeks ago, she had an infarction, myocardial infarction. Now, she is recovering and as well as feeling well. Now, when she is recovering and as well as feeling well, why are you suspecting this particular new anterolateral wall motion abnormality? No, this is completely out of the story. Which one? New anterolateral wall motion abnormality. Now, what is the abnormality you are seeing in the ECG now? Right? Let me come to the ECG. Let me discuss the ECG. So, in the ECG, you are able to make out that there is ST elevation in V1, ST elevation in V2. There is also ST elevation in V3 and mild ST elevation even in case of V4 as well. And along with that, what is that you are observing? You are observing that there are T-wave inversions. T-wave, it is inverted. Right? T-wave, it is inverted. Now, in case of new anterolateral wall motion abnormality, because many of you were answering E, that is new anterolateral wall motion abnormality. This is not the answer. This is not correct. Can anyone tell me why? Why E is not the correct answer? Any one of you? Why do you think E is not the correct answer? Yes. So is there anyone who can tell me why E is not the correct answer? Right. So one point is that she had a myocardial infarction 7 weeks ago. And other point suggestive of new anterolateral wall MI. How will be the T wave in case of new anterolateral wall MI? In case of new anterolateral wall MI, they will have tall T wave. Right? They will have tall T wave. So, but in this ECG, what is that you are seeing? In this ECG, you are seeing that there is a T wave or T wave is being inverted. So this is the ECG of your, this is the ECG of your new anterolateral wall MI. You see here how much tall T wave do you have? This is a tall T wave. This is a tall T wave. This is your tall T wave. And along with that, you are also having ST elevation. This will be the ECG of the new anterolateral wall MI. So anterolateral wall MI means in which all leads you will have ST elevation. In case of 1, AVL, V5, V6, there should be ST elevation. And not only that, even V1 to V4, also there should be ST elevation. Right now you see here, in anterolateral wall MI, you can make out here, 1, there is ST elevation and tall T wave. AVL, ST elevation and tall T wave. Then you take V5, V6, ST elevation is there. And along with that, you also have tall T wave. Right? Along with that, you also have tall T wave. So this is the ECG suggestive of new anterolateral wall MI. Right? This is the ECG in case of new anterolateral wall MI. But whatever is the ECG which is given in your question, it is showing the ST elevation. Only ST elevation is there. So in ventricular aneurysm, this is also one of the conditions where you have ST elevation. Ventricular aneurysm is also one of the conditions where you will have the ST elevation. Okay, right. Now, can anyone tell me what are all the other conditions where you will have ST elevation? Can anyone answer this? What are the apart? So ventricular aneurysm, you will have ST elevation. MI, you will have ST elevation. What are the other conditions where you have ST elevation? Yes. Who will be the first person to answer this? Very good, Nirbhay Kumar. Excellent. Superb. Right. So in pericarditis. So in pericarditis, you will have ST segment elevation. Very good, Nirbhay Kumar. And the other one is vasospastic angina. And vasospastic angina means what? It is nothing but your Prince metal angina. So vasospastic angina or Prince metal angina, it is one and the same. So these are all the conditions. Yes, even whenever there is disorder of the potassium. Whenever there is disorder of the potassium. So even in hyperkalemia, you can have this particular ST elevation. Okay, right. Now, followed by that, you take the ECG in large pericardial effusion. Can anyone tell me how will be the ECG in large pericardial effusion? Yes, very good, Avinash Mukherjee. Even in your left bundle branch block as well. Even in your left bundle branch block as well. Good. Yeah. So please tell me what will be the ECG in large pericardial effusion. Any one of you, please? Oh, very good, Avinash. Excellent. Superb. So, in case of large pericardial effusion, very good, Nirbhay Kumar, they will have what is called as the low voltage complexes. So, low voltage complexes. This will be the ECG in large pericardial effusion. Now, the point is, what is the criteria for low voltage complexes? The criteria for low voltage complexes is that the QRS complexes, they should be less than 5 mm in limb leads. The QRS complexes, it should be less than 10 mm in the chest leads. Right, it should be less than 10 mm in the chest leads. This is about what is called low voltage complexes. Now, low voltage complexes, they are present in large pericardial effusion. What are the other conditions? What are the other conditions where you will have low voltage complexes apart from large pericardial effusion? Any one of you? Yes. Excellent, Nirbhay Kumar. So the other conditions where you will have low voltage complexes is you will have this in patients with the obesity. You will have this in patients with the constrictive pericarditis. You can have this in patients with the hypothyroidism, that is myxedema. Right, hypothyroidism. Okay, so these are all the conditions, yes, even in your COPD as well. So these are all the conditions where you will have low voltage complexes. Yes, Avinash, cardiac tamponade, do you have low voltage complexes or any other? Yes, Avinash, please answer this ECG. Can anyone tell me the diagnosis of this ECG? What is the diagnosis of this ECG? Very good, Avinash, excellent. So in the diagnosis of this particular ECG is electrical alternance. So electrical alternance you will have in cardiac tamponade. In cardiac tamponade you will have the electrical alternance. You will not have low voltage complexes in cardiac tamponade. We will have what is called electrical alternance. Now, electrical alternance means what? You observe this ECG here. One complex is large and the alternate complex will be small. One complex will be large and the alternate complex will be small. So, large and small amplitude complexes. Large and small amplitude complexes. That is what will give you what is called electrical alternance. That is what will give you a picture of what is called electrical alternance, and that is suggestive of cardiac tamponade, right? Next, now followed by that, yeah. So where do you get this calcified pericardium? Calcified pericardium, you will have this in patients with a constrictive pericarditis. You will have this in constrictive pericarditis, you will have calcified pericardium, and there you have low voltage complexes again. Now, can anyone tell me what will be the ECG change in biatrial enlargement? What will be the ECG change in biatrial enlargement? Any one of you, please? What will be the ECG change in biatrial enlargement? Yes, Gayaz Mohammed. Electrical alternance is seen in cardiac tamponade. In cardiac tamponade, you will have electrical alternance. Right, very good, Avinash. So biatrial enlargement, you will have, this is the ECG of your biatrial enlargement. Sorry. So this is your P mitral. The P mitral, you will have this in patients with the mitral stenosis, where you can make out the P wave, it is of M shape. Right, it is of M shape. Whereas this is the ECG in patients with the tricuspid stenosis. So in P mitral, it is seen in left atrial enlargement. P mitral, it is seen in left atrial enlargement. Whereas P pulmonale, you will have this in patients with a right atrial enlargement. Right atrial enlargement. Which one? The P pulmonale. P mitral in the left atrial enlargement. P pulmonale in the right atrial enlargement. If you have a both mixed, right? If you have this both mixed, then we call it as biatrial enlargement. Now the point is, what is the criteria? What is the criteria? See, the criteria is that for the P mitral, right? For the P mitral, the duration of the P wave should be more than 120 milliseconds. That is a criteria for P mitral, and along with that, it should be of M shape. It should be of M shape. Next, whereas P pulmonale, if you take the amplitude should be more than 2.5 millimeters. The amplitude should be more than 2.5 millimeters. That is in right atrial enlargement, that is P pulmonale. So we have P mitral and as well as the P pulmonale. Okay, right. Now, so that completes the discussion of this particular multiple choice question. So ventricular aneurysm is what you will see in this ECG, and even the history also. 7 weeks ago, myocardial infarction, and ventricular aneurysm, it is one of the complications what you will see in MI. Ventricular aneurysm is one of the complications of the myocardial infarction. So based on the background history, we should be able to tell that this particular patient is having ventricular aneurysm. Okay, history is very important in this patient. Right. Now we will move on to the next question. Yes. Is anyone convinced with this ECG and as well as ruling out the other options? Please let me know. Is everyone convinced with the other options also? Very good. Excellent. So now we will move on to the next question. Yes. This is another interesting image. A pair of siblings have multiple brown macules and nodular lesions on their skin. Their father has similar lesions. All of the following are part of the diagnostic criteria for this patient except axillary or inguinal freckling, 2 or more leash nodules of the iris, positive family history, 6 or more diffuse macules, adenoma sebaceum. The question asked is except. The question asked is except. Avinash, don't be in a hurry. Please don't be in a hurry, Avinash. See the question. The question asked is except. Yes, so Chandia has answered and as well as Shravan Kumar has answered. The answer is adenoma sebaceum. See, adenoma sebaceum, so what is the diagnosis here? Definitely yes, neurofibromatosis type 1. In neurofibromatosis type 1, do you have adenoma sebaceum? No. Right? Adenoma sebaceum is seen in which disorder? Avinash, abhi bolo. In which disorder you have this adenoma sebaceum? Adenoma sebaceum, very good Avinash. So adenoma sebaceum, it is seen in patients with tuberous sclerosis. What does this patient has? This patient is having neurofibromatosis type 1. So that is the reason why the answer is not adenoma sebaceum. Now, in case of the neurofibromatosis type 1, in case of neurofibromatosis type 1, what all lesions do you have? Right? So you should be, everyone should be aware of this mnemonic called cave spot. So please be very careful when you are answering. So everyone should be aware of this particular cave spot. Now, what is this particular cave spot? The word C is your Caffew spots. These are the features of neurofibromatosis type 1. The word C stands for Caffew spots. The word A is your axillary freckling. Right? The word A is your axillary freckling. The word F is your fibroma. What fibroma is that? Neurofibroma. The word E stands for eye signs. What are those eye lesions? That is presence of Lisch nodules. That is the presence of Lisch nodules. And you take this SPOT. S stands for skeletal changes. S stands for skeletal changes. P stands for positive family history. Right? Positive family history. And the word OT stands for optic tumor. Right? OT stands for optic tumor. And what is that optic tumor? Glioma. Right? What is that particular optic tumor? Glioma. And in neurofibromatosis type 1, so can anyone tell me which chromosomal abnormality do you see? What is a chromosomal abnormality you will see in neurofibromatosis type 1? Yes, the chromosomal abnormality is, it is the chromosome number 17. Acha, very good. Avinash has already said. Now, how to remember that? Yes, Avinash, how do you remember chromosomal number 17? So, if you count this neurofibromatosis, if you count this neurofibromatosis letter, you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So you have 17 letters in neurofibromatosis. So please remember that is chromosome number 17. Chromosome number 17. Right? Yes, Gayaz Mohammed, your chromosome number 22 is your neurofibromatosis 2. It is your neurofibromatosis 2. Okay? Right. Now let me just show you the other images as well. Now, can anyone tell me what is the diagnosis of this? What is the diagnosis of this image? Yes, Chaitanya, can you tell me what is the diagnosis of this image? So this is the patient. Very good. So this is the patient with adenoma sebaceum. Right, which is seen in tuberous sclerosis. Which is seen in tuberous sclerosis. Right. And you see the next image. So can you tell me what is this? Can anyone tell me what is this particular lesions in patients with the neurofibromatosis type 1? So these particular lesions, they are nothing but your Caffew spots. These lesions are nothing but the Caffew spots. Okay. No. Shweta, these are not Lisch nodules. These are your Caffew spots in patients with neurofibromatosis type 1. And, okay, so these are flat pigmented birthmarks. Right, flat pigmented birthmarks. Then, now, yes, Santosh Giravina. Santosh, so please tell me what is this? Yes, Venkatakishore. Please tell me what are these lesions? These are your, where are these lesions present? They are present in the axilla. So these are your axillary freckles. These are your axillary freckles. Okay, so please remember that these are your axillary freckles. Okay, right. Next, then followed by that, yeah. So these are your fibromas. These are your fibromas in neurofibromatosis type 1. right? Okay. Now, can anyone tell me what is this? What are these lesions in neurofibromatosis type 1? What are these lesions in neurofibromatosis type 1? Any one of you? Very good, Avinash. So these are nothing but your Lisch nodules. Nahi, optic tumor nahi hai wo. These are Lisch nodules. Optic tumor you cannot see barely. Optic tumor you have to do MRI. You have to do MRI in order to make out optic glioma. Okay, so these are your Lisch nodules. So these are Lisch nodules which are nothing but melanocytic hamartomas. And these are dome-shaped elevations. These are dome-shaped elevations. Okay, so these are all the lesions which will be there in case of, yeah, this is your bony abnormality. And can anyone tell me what is the bony abnormality you will see in neurofibromatosis type 1? Yes, bony abnormality in neurofibromatosis type 1. So this particular bony abnormality, whichever arrow is pointing towards, they are nothing but your sphenoid dysplasia. It is nothing but your sphenoid dysplasia. Okay. So to summarize everything now, So in patients with the neurofibromatosis type 1, these are your CAFU spots, which are flat pigmented patches. These are axillary freckles seen in neurofibromatosis type 1. These are neurofibromas. These are Lisch nodules seen in neurofibromatosis type 1. This is your sphenoid dysplasia, right? This is your sphenoid dysplasia. Okay, right. And the gene which is being mutated is multiple mutations in a gene of GTPase that is involved in the development of this particular neurofibromas. Right. Now, this is another very interesting question. History is very important in this patient, I am telling you. Right? The question which I am showing, history is very, very important. I have a 13-year-old Sephardic Jewish boy had recurrent fever, abdominal pain, arthritis, pleuritic chest pain, and the skin lesions are shown here. What is the treatment of choice in this patient? Nafcillin, cephalexin, colchicine, prednisolone, acetaminophen. So who can tell me the diagnosis? Based on the history and the lesion, whatever you are seeing over the lower limb, what will be the diagnosis? Now, first of all, please tell the diagnosis. No, I did not get the correct answer. Okay, so Shweta has answered. Very good, Shweta. Shweta, can you tell me the diagnosis? Colchicine is the answer. But what is the diagnosis? नहीं वो cellulitis नहीं है. No, Avinash, it is not sarcoidosis. Okay, you see the history. This point is very, very important, Avinash. 13-year-old Sephardic Jewish boy. Excellent, superb, Avinash. So the answer is familial Mediterranean fever. The answer is familial Mediterranean fever. Okay, so what is this familial Mediterranean fever? Let me explain you about this familial Mediterranean fever. Familial Mediterranean fever, it is an autosomal recessive disease, right? And it mainly affects Sephardic Jewish people. mainly affects Sephardic Jewish people. And this familial Mediterranean fever, this is also commonly seen in children. Right? This is also commonly seen in children. Yeah, so the word Jewish is the word which is giving you a complete hint towards the diagnosis of this patient. Okay. Now in familial Mediterranean fever, what all structures are affected? There will be pleural involvement, peritoneal involvement, and there will be also involvement of the synovium. So pleura, peritoneum, and as well as the synovium. So now what will be the features in these patients with the familial Mediterranean fever? They will have fever, abdominal pain, chest pain, arthritis, erysipelas like rash. So whatever the image given to you there, right? Whatever the image which is given to you there, it is erysipelas like rash. Now the question is, what is the treatment for your familial Mediterranean fever? The treatment for familial Mediterranean fever, it is nothing but the colchicine. Right? Colchicine should be given. Now, the question is, how will you confirm this? How will you confirm the diagnosis of this familial Mediterranean fever? One is your history, and the other thing is there will be raised ESR, there will be increased WBC count, there will be increased fibrinogen levels, right? And there will be hematuria and proteinuria. There will be hematuria and as well as proteinuria. So these are the investigations which are suggestive of the familial Mediterranean fever. Okay, so familial Mediterranean fever, like what is the treatment that you should give? Colchicine has to be given, right? And what all will be the features? Recurrent fever, abdominal pain, arthritis, pleuritic chest pain, and the skin lesion. And what is that skin lesion? It is erysipelas. It is erysipelas. Right, next. No, the same. Yes, Gopalakrishnan. Whenever you are giving this colchicine prophylaxis, this has been shown to reduce the frequency of amyloidosis. This has been shown to reduce the amyloidosis. That is what is given there. That's all. TK. Now you take the other question. We have a 34-year-old woman complains of daily fevers and evanescent rash. This point is very, very important to me. This point is very, very important. Evanescent rash, right? And along with that, she is also having arthritis. Okay, but rheumatoid factor, anti-nuclear antibody, Lyme serology, everything is negative. Right, everything is negative. And ferritin value is 1200 micrograms per liter. Ferritin value is 1200 microgram per liter. What is the most likely diagnosis in this patient? And this is your rash. Infectious endocarditis, adult onset Still's disease, Bancrofttian fever, relapsing fever, quotidian fever. Right, good, very good, Avinash, excellent. So it is, the diagnosis is adult onset Still's disease. The diagnosis is the adult onset, the Still's disease. Right. Now, what are the points in favor of your adult onset Still's disease? It is the presence of evanescent rash and arthritis and daily fever. The ferritin levels will be elevated in these patients. The ferritin levels will be elevated in these patients with the adult onset Still's disease. Now, let me tell you a few points of this adult onset Still's disease. See, rash, whatever is being described as, is evanescent rash, right? And that is salmon pink coloration, which is salmon pink coloration. And there are multiple diagnostic criteria for the adult onset Still's disease. But the criteria what we follow for adult onset Still's disease is Yamaguchi's criteria. Right, Yamaguchi's criteria. So you may, those students who are listening to this particular disorder for the first time, you may think that it is looking, everything is looking like Greek and Latin. But let me tell you, these are the things which will definitely appear in your exams. Right? The level of exam of your FMGE has increased a lot. Please don't be under the impression of still that single liner questions and all. Right? The quality of the examination of your FMGE exam has way increased a lot. The questions are like unimaginable. And these are the type of questions which you will be getting your in exam. So we at Arise Medical Academy are preparing you for the toughest questions which you will be getting in your FMGE exam. Okay? Right. And this Yamaguchi's criteria, let me tell you, you have major criteria and as well as minor criteria. What is a major criteria? Fever, arthralgia, typical rash, and leukocytosis. Now, what does our patient has? Our patient has everything now. Our patient is having rash. Our patient is having fever. Our patient is also having arthritis. Everything is there in our patient. That means this patient is satisfying the major criteria of Yamaguchi for adult onset Still's disease. Right? For adult onset Still's disease. And apart from that, you also have minor criteria like sore throat, lymphadenopathy, splenomegaly, liver dysfunction, and absence of rheumatoid factor. Now, how will you diagnose? What is the diagnostic criteria? Diagnostic criteria is that if two or more major criteria are there, right, more than or equal to 2, if major criteria are there of Yamaguchi, then you can diagnose adult onset Still's disease. But if you want to diagnose based on the minor criteria, it should be more than or equal to 5 minor criteria. Right, more than or equal to 5 minor criteria. Based on that, you will be able to diagnose the Yamaguchi's adult onset Still's disease. Right now, yeah, and I have said you that the ferritin levels will be elevated in these patients characteristically. And if the ferritin levels are elevated, what does that tells you? If the ferritin levels are elevated, that tells that the individual is having very active disease. Right, the individual is having very active disease. That is what is the meaning of this word, the ferritin level being elevated. Okay, next. And apart from that, what is the treatment now? What is the treatment? See, arthritis is there in this individual, fever is there in these individuals. So what is that you want to give? You have to give NSAIDs. Right, you have to give NSAIDs in these individuals. Okay, right. So that is the diagnosis of this particular patient, that is adult onset Still's disease. Now, can anyone tell me what is this Bancroftian fever? Yes, Avinash, what is this Bancroftian fever? What is Bancroftian fever? What is relapsing fever? What is quotidian fever? Right, very good. So, Bancroftian fever is nothing but filariasis. That is Wuchereria bancrofti. That is Wuchereria bancrofti. Then, yes. Now, what is this relapsing fever? What is relapsing fever? What is the organism? No. Relapsing fever, you tell me. Relapsing fever, Madhubala. Okay, quotidian fever, Noleski, good. Relapsing fever, very good. So very good, Avinash. So your relapsing fever, it is caused by what is called as Borrelia recurrentis. Borrelia recurrentis is the one which will cause the relapsing fever. Okay, just 1 second. Right, so Borrelia recurrentis is the one which will cause the relapsing fever. Okay, right, and whereas Borrelia burgdorferi, it will cause Lyme disease. Borrelia recurrentis, relapsing fever. Borrelia burgdorferi, Lyme disease. Right, now there was one more option called quotidian fever. What do you mean by the word quotidian fever? What do you mean by this word quotidian fever? Yes, Avinash, on the YouTube, like there is a lag. There will be a lag of almost like 15 seconds. 15 seconds, there will be a lag. Right. So if you take this particular quotidian fever, you will see that 9. See, quotidian fever is that you will have the fever every day, not every 4 days apart. Nahin. Quotidian fever is that where you will have the fever every day. Alternate day fever is tertian fever. Alternate day fever is tertian fever. Right? And where do you have this quotidian fever? That is Plasmodium knowleski. Where do you have tertian fever? Plasmodium vivax and Plasmodium ovale. And quartan fever is that you will have the fever for every 2 days. You see here, there is no fever, there is no fever, and here you will have the fever. Quartan fever, like you will have the fever for, that means 2 days no fever, the next day fever, 2 days no fever, the next day fever. Right? That is what is your quartan fever, and that you will see in patients with the Plasmodium malaria. So please remember, the quotidian fever is that it is not every 4 days apart. Nahin. It is every day. It is every day. Okay. And where do you see that? That you see in patients with the Plasmodium knowleski. Right? Okay. So that finishes the discussion of this particular question on the adult onset Still's disease. See, I am discussing each and every option, and this is how you have to analyze the clinical questions. This is how you have to analyze and prepare for your exams. Okay. Yes, another very interesting question, and let me see how many of you can answer this. An 18-year-old man presents to your office for medical clearance, right? For medical clearance, and he is participating in the fall sports. Okay, the baseline ECG is shown here. This patient is most likely associated with which of the following congenital anomaly? Atrial septal defect, ventricular septal defect, tetralogy of Fallot, dextrocardia, Epstein's anomaly. Yes. Right. So what is the answer here? No, I did not get the, okay. So I got the correct answer from few of you. So can anyone tell me what is the diagnosis of this ECG? Right. Please tell me the diagnosis of this ECG. answer is E. The answer is definitely E, Epstein's anomaly. But it is not the diagnosis. Diagnosis is not Epstein's anomaly. Very good, Avinash. Excellent. So the diagnosis in this patient is WPW syndrome. Right? Diagnosis in this patient is WPW syndrome. That is Wolff-Parkinson-White syndrome. Right, Wolff-Parkinson-White syndrome. Okay, so now what will be the ECG features of Wolff-Parkinson-White syndrome? Now let me explain you. This is what is the ECG picture of WPW syndrome. So what all you will have is, you will have short PR interval, right, and you will have wide QRS complex. Then you will have delta wave. Right, so this is your delta wave. The one which is given in the arrow, that is your delta wave. That is your delta wave. So these are the ECG features in patients with the WPW syndrome. And the same thing is given in your ECG complex also. If you see here, okay, now we will take one strip. We will take rhythm strip, that is lead 2. This is your delta wave, and you take the PR interval. The PR interval, it is shortened. Can anyone tell me what is a normal PR interval? Can anyone tell me what is a normal PR interval? What is the duration of normal PR interval? So if you take the duration of normal PR interval, it is 0.122 to 0.21 seconds. Okay, that is the duration of the normal PR interval. Short PR interval means what? That is less than 0.12 seconds. Less than 0.12 seconds. Yeah, so 0.12 to 0.21 is nothing but 120 to 200 milliseconds. 120 to 200 milliseconds is your normal PR interval. Okay, now let me tell you what is actually WPW syndrome. It is a pre-excitation syndrome. Right, it is nothing but your pre-excitation syndrome, where you have the presence of accessory pathways. I'll show you that accessory pathway. Now you see here, normally between the SA node and AV node, you have only 3 pathways. You will have normally only 3 pathways. What are those? Anterior, middle, and posterior internodal fibers. Right, you have anterior, middle, and posterior internodal fibers. So these are the 3 pathways what you will have normally. But in WPW syndrome, you see here, this is your accessory pathway. This is your accessory pathway. So because of this accessory pathway, the ventricle will undergo pre-excitation. Right, the ventricle will undergo pre-excitation. Okay, it is yes, Gayaz Mohammed, it is the accessory pathway, the one which is responsible for your WPW syndrome. That is accessory pathway, that extra bundle. That is what, and the point is, this WPW syndrome, it is very common in individuals with the Epstein's anomaly. WPW syndrome, it is common in patients with the Epstein's anomaly. Okay, now what is Epstein's anomaly? The Epstein's anomaly is that, you see, this is a normal heart. Now let me explain you, comparing that with your normal heart. In the normal heart, this is the tricuspid valve that is in between right atrium and right ventricle. So between right atrium and right ventricle, this is the tricuspid valve. And where is the tricuspid valve positioned? That is near to your pulmonary artery. Now, okay, now what happens in the Epstein's anomaly? In Epstein's anomaly, there will be distal displacement of the valve. Right, in Epstein's anomaly, there will be distal displacement of the valve. That is what is called Epstein's. Distal displacement of which valve? Tricuspid valve. The tricuspid valve, which should be at this position, you see here. This will undergo distal displacement. And this is one of the congenital anomaly. This is one of the congenital anomaly. Okay, so that is what is your Epstein's anomaly. And in Epstein's anomaly, WPW syndrome is very common. In Epstein's anomaly, WPW syndrome is very common. Now, what will be the clinical features of WPW syndrome? No. They will not have sudden cardiac death, cytherny. What they will present is, they will present with palpitations. And WPW syndrome, it is one of the etiology which will cause paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia. Now, what is the treatment? What is the treatment? The treatment is ablation of the treatment is ablation of accessory bundle by radio frequency ablation. Okay, radio frequency ablation. Right, that is a treatment for, that is a permanent treatment. This is a treatment of choice. This will be the treatment of choice in patients with the WPW syndrome. Right, next. Now we will move on to the next important clinical question. I hope everyone has understood this. There should not be any problem in this, right? So please just give me a feedback until now. How are the questions? Yes, please just give me a feedback until here. How are the questions? And am I going with adequate speed or am I going fast? So how do you feel the session is going on? Because your feedback will be very important for me to progress with the remaining part of the session as well. Right. If you see the next question. Yes. Thoda difficult question. It is a difficult question, and let me see how many of you can answer. The ulcer shown here, this is the ulcer. Right, and this is seen in a 30-year-old woman. And along with this ulcer, what is the patient having? The patient is also having hypertension, arthralgia, fatigue, abdominal pain, mononeuritis multiplex. This is very, very important to me. This history is very important to me. And even biopsy. What is the biopsy showing? Necrotizing vasculitis. Which of the following tests is most likely to have abnormal result? C. ANCA, blood eosinophil count, chest radiograph, urine analysis, ECG. Please give me the diagnosis. No. It is not A. Everyone is answering C Anka, but it is not C Anka. Minus, it is not Wegener's granulomatosis. It is not Wegener's granulomatosis. In Wegener's granulomatosis, what does the biopsy show? Yes, minus. Please tell me. In Wegener's granulomatosis, what does the biopsy show? Biopsy in Wegener's granulomatosis, it will show granulomatous lesions. It will show granulomatous lesions in Wegener's granulomatosis. And C Anka, it is present in Wegener's. C Anka, it is present in Wegener's. In Wegener's, you will not have necrotizing vasculitis. You will have granulomatous vasculitis. No, it is not venous ulcer. Right. So, the diagnosis in this patient is polyarteritis nodosa. In polyarteritis nodosa, you will have mononeuritis multiplex. You will have abdominal pain. Then fatigue. Then the ulcer like what you see over the lower limb. The ulcer, what you see over the lower limb. That is what you will see in the polyarteritis nodosa. Okay. Next, the other point is in these patients with the polyarteritis nodosa, even hypertension is also there. And what is polyarteritis nodosa? It is a medium vessel vasculitis. Right? It is a medium vessel vasculitis. Okay. Now, in case of polyarteritis nodosa with medium vessel vasculitis, where is that abnormality you will come across? The abnormality you will see in the urine analysis. The abnormality what you will see is in the urine analysis. So urine analysis will show proteinuria. Urine analysis will show proteinuria. Okay. Now, so the answer here is D. The answer here is D. Now answer. Now what is the diagnosis? WG stands for Wegener's granulomatosis. What is the diagnosis of this patient? What is that? So the diagnosis here is saddle nose. Right? This is saddle nose. So in Wegener's granulomatosis, you have a triad. There will be involvement of upper respiratory tract. There will be involvement of lower respiratory tract. There will be involvement of kidney. There will be involvement of kidney. That is what you will see in Wegener's granulomatosis. Okay. But what is given in our patient? Mononeuritis multiplex is there. The hypertension is there. Ulcer is there. Arthralgia is there and abdominal pain is there. These are all not the features of your Wegener's granulomatosis. And you take the eosinophil test. Where will you do that? In Church-Strauss syndrome. Now, is this clinical history suggestive of Church-Strauss? No. This is not the history suggestive of Church-Strauss. So, now what is making me to think of polyarteritis nodosa? That is mononeuritis multiplex. Abdominal pain and as well as ulcer, which is seen over the foot. And the other important point in the history which is making me to think of the, Avinash, it is not rhinophyma. No, it is not rhinophyma. It is a saddle nose that is due to perforation of the nasal bridge. Right. And the other thing which is telling me the diagnosis in this patient is about the necrotizing vasculitis. Now, what is the, okay, answer this. Okay, if this condition, if polyarteritis nodosa were due to an infection, which of the following would be most likely infection? Bacterial endocarditis, mycoplasma pneumonia, leptospirosis, syphilis, viral hepatitis. Yeah, tell me, if this condition was due to infectious disease, which of the following condition would be the most likely diagnosis? No. Leptospira does not cause the polyarteritis nodosa. Now, let me tell you the answer. No, I am not getting the correct answer from any one of you. Very good, Avinash, excellent. So, it is your hepatitis C. Hepatitis C and as well as hepatitis B, both, Avinash, both hepatitis B and as well as hepatitis C, that is what is responsible for the development of your polyarteritis nodosa. Right, hepatitis B and hepatitis C infection have been associated with the development of the polyarteritis nodosa. Okay, now what is the treatment in these individuals? Like for example, if the polyarteritis nodosa, if it is secondary to viral infection, then you need to give antiviral drugs and as well as interferon alpha. Right, you need to give antiviral drugs and as well as the interferon alpha. So that is about the treatment. Right, next. Now, yes, and if it is not associated with the viral hepatitis, then the treatment for polyarteritis nodosa is corticosteroids and cytotoxic agents like cyclophosphamide and azathioprine. So if polyarteritis nodosa, if it is due to viral hepatitis, antiviral drugs and interferons should be given. If the polyarteritis nodosa, if it is not associated with hepatitis B or hepatitis C, then you need to give corticosteroids and cytotoxic agents such as cyclophosphamide and azathioprine should be given. That is the treatment of polyarteritis nodosa. All right. Now, so the answer to this particular question is urine analysis is the first answer, then viral hepatitis is the second answer. Okay, right. Now we will move on to the next question. Yeah, this is another very interesting question, and diagnosis, no one should miss the diagnosis. No one should miss the diagnosis. A previously healthy 26-year-old man presents with 3-week history of abdominal pain and arthralgia. On examination, hypertension and palpable purpura of the lower extremities are found. Urine analysis shows hematuria. What is the most likely diagnosis? And the same patient's lower limbs image is given and the same patient's abdominal X-ray is given. Tell me the diagnosis. Options are Henoch-Schonlein's purpura, cryoglobulinemia, hypocomplimentic vasculitis, rheumatoid vasculitis, systemic lupus erythematosus. Right, superb. So the diagnosis is Henoch-Schonlein's purpura. Diagnosis is Henoch-Schonlein's purpura. So based on the history itself, you can tell the diagnosis. Based on the history itself, you will be able to tell the diagnosis. No, Sharad, it is not triad, it's a tetrad. You will have a tetrad in Henoch-Schonlein's purpura. What is that tetrad? Let me tell you. H, S, P. Hematuria, skin lesions will be in the form of purpura. The other P, it is a pain. Pain in the joints and pain in the abdomen. Right, pain in the abdomen. Okay, that is a tetrad in Henoch-Schonlein's purpura. HSP. Okay. Now you people should tell me now what is this image of the abdominal X-ray? What is the diagnosis? What is the diagnosis of the abdominal X-ray there? Now on the lower limbs though, like whatever you are seeing here, this is your palpable purpura. That is okay. Please tell me what is the abdominal X-ray finding? So this abdominal X-ray finding, this is suggestive of intussusception. Like you have multiple intestinal obstructions are there. Multiple intestinal obstructions are there. So what is that you are seeing in the abdominal X-ray? Actually, it is suggestive of bowel obstruction, right? And therefore there is air fluid levels and bowel dilatations are there, right? There are multiple air fluid levels and bowel, it looks like completely dilated. That is suggestive of intussusception. And it is because of this intussusception only, the individual with the Henoch-Schonlein's purpura, they will have abdominal pain. They will have abdominal pain, right? Are Chaitanya, concentrate on the class. Later I will give you the address of all the students. Where is Taruni from? Where is everyone? I will give you the address later. I'll give you their phone numbers also, but please concentrate on the class. Right. Okay, so now, where are we now? Yeah, the treatment. So can anyone tell me what is the treatment of Henoch-Schonlein's purpura? What is the treatment of Henoch-Schonlein's purpura? Right. So the treatment of Henoch-Schonlein's purpura is the steroids. Steroids are the drug of choice for the नहीं Gayaz Mohammad, क्या बात कर रहे हैं? Why do you give acetaminophen in these patients? Steroids are the drug of choice. Okay, right. And the other point is you should know now, because there is palpable purpura, I wanted to ask you one question. There is palpable purpura. I wanted to ask you one question. Please tell me what will be the platelet count in these individuals? Please tell me what will be the platelet count in these individuals? That is what. So I was waiting for this answer. I was waiting for this answer. In Henoch-Schonlein's purpura, yes, Avinash, can you tell me what will be the platelet count in Henoch-Schonlein's purpura? Any one of you rather? Yes, very good. So they will have either normal platelet count or they will have thrombocytosis. They will have either normal platelet count, right? Most of the time it will be normal platelet count, right? Occasionally, rarely you can have this thrombocytosis. But remember, in Henoch-Schonlein's purpura, there is no thrombocytopenia. There is no thrombocytopenia. Then, my next question here now is, sir, if there is no thrombocytopenia, then why is this purpura? Can anyone tell me? Sir, you are saying that there is no thrombocytopenia, but then why is the purpura then? Can anyone tell me? So, the purpura in these patients is due to cutaneous vasculitis. Right? The purpura in these individuals is due to cutaneous vasculitis. Okay? So due to cutaneous vasculitis, you will have this particular palpable purpura. And remember, in Henoch-Schonlein's purpura, they will not have thrombocytopenia. They will have normal platelet count. Normal platelet count. Okay? Yeah, it is your IgA vasculitis. IgA deposits will be there. Biopsy will show vasculitis with IgA deposits. Answer this. A patient was bitten by a cat. Very bad, right? Very, very bad. A patient was bitten by a cat. All of the following may be appropriate treatment in the setting of resulting infections, except. That means which one you should not give in the patient. Human rabies diploid vaccine, tetanus toxoid booster, human rabies immunoglobulin, cephalexin, amoxicillin or clavulinate. So you see that cat bite marks, very badly bitten. The individual had a very bad day. Now tell me, the question asked is except, which is a false statement. So what is the organism which will be spread by your cat bite? What is the organ? So diagnosis is very simple. It is cat bite associated disease. Magar, like what is the organism that will be spread? So the organism that is being, actually the answer here is D. I will tell you why. This is the answer. We should not give cephalexin. We should not give cephalexin. Why we should not give cephalexin? I will tell you. I will tell you. Right? The organism which is being spread by your cat bite is Pasturella multocida. Rabies, it is not dog bite, vinous. It is not dog bite. It is a cat bite. In dog bite, rabies. In cat bite, it is Pasturella multocida. That is the most common infection after the bites. And what is Pasturella multocida? It's a gram-negative cocobacillus. And not only Pasturella multocida, even other causes of local infection is also there in case of cat bite fever. What are the other infectious organisms? Staph, strep, and as well as anaerobes. Now, this Pasturella multocida, right? Remember this point. This particular Pasturella multocida, this organism, it is resistant to your cephalexin, right? It is resistant to cephalexin. right? Now, yes, Chaitanya, you have response from Taruni. Right. So, what is the treatment for Pasteurella maltosida? The treatment for Pasteurella maltosida is amoxicillin clavulinate. That is acceptable treatment. Right? It is not cephalexin. It is not cephalexin. Pasteurella maltosida, it is resistant to dicloxacillin. It is resistant to cephalexin. It is resistant to clindamycin. Right? Yes, Chaitanya is not there. Chaitanya disappeared. Ah, yes, he's there. Good. Right. Now, like you take the rabies, rabies may manifest with hydrophobia, copious salivation, encephalitis, or myelitis. But in rabies, definitely what is required, you should require the demonstration of the Negri bodies. Demonstration of the Negri bodies. That is very, very important in the diagnosis of the rabies. But definitely what is not required to be given in these individual? Cephalexin. Why cephalexin should not be given? Because Pasteurella multisida, it is resistant to your cephalexin. It is resistant to your cephalexin. Okay? Right. Last question for the day. Right? Last question for the day. Yes, Santosh, what has distracted you? No one is saying hi for you, बोल के distract हो गया. So is there anyone who wants to tell hi to Santosh? Right. So now let us come back to the question. A 77-year-old man arrives in the emergency department. Yes, Vinus, if rabies is not the infectious agent here, why are we giving the vaccine for the, okay, good question. Right. Okay. Yes. Now you take here the human rabies diploid vaccine and human rabies immunoglobulin. This can plus or minus. It can be given or need not be given. It is not a mandatory thing. But definitely the best answer here will be cephalexin. The best answer here is cephalexin. Okay, but your human rabies diploid vaccine, it may or may not be given. Right? It is not required. As you have said, it is not required. But what is the best answer here? Cephalexin should never be given in these individuals. Okay. Right. Last question for the day. Right. So we have a 72-year-old man arrives in the emergency department complaining nausea and vomiting. The ECG obtained is shown here. Which of the following do you conclude? Acute pericarditis, lateral myocardial infarction, anterior myocardial infarction, posterior myocardial infarction, non-cardiac cause for the patient symptoms. Non-cardiac cause for the patient symptoms. What is the answer? No. It is not anterior wall MI. Gayas. Very good. So Shweta has answered. Very good, Shweta and Avinash. So this is the ECG of posterior wall MI. This is the ECG of posterior wall MI. Now in posterior wall MI, what will be the ECG changes? So what I will do is, first I will tell you what will be the ECG changes in posterior wall MI. Then I will come back to the ECG once again. Okay. So in posterior wall MI, you will have ST depression in leads V1 to V3, and there will be also dominant R wave, right? There will be also dominant R wave in V1 to V6, sorry, V1 to V3. Now, what do you mean by the word dominant R wave? You see, this is the dominant R wave. What is ST depression? This is your ST depression. Now, why are you telling dominant R wave, sir? Normally, from V1 to V3, there is no dominant R wave. Normally, from V1 to V3, you will not have a dominant R wave. The R wave will start appearing from V3. In V1 and V2, you will have a very small R wave. From V3, V4, the R wave, it will start appearing. Right? It will start appearing. Okay. So now, with these findings, whatever I have taught you regarding the posterior wall MI, now we will go back to the question. Now you go back, you see this question now. So there is ST depression in V1 to V3, and there is dominant R wave in V2, V3, and to certain extent even in V1 also. Okay, so this is the ECG suggestive of the posterior wall MI. Now you take in acute pericarditis. What will be the ECG changes in acute pericarditis? Can anyone tell me? What will be the ECG changes in acute pericarditis? So, if you take the ECG changes in case of acute pericarditis, you will have widespread, you will have ST elevation in all leads except AVR. You will have ST elevation in all the leads except AVR. In AVR, you have ST depression. In AVR, you have ST depression. Okay. Now, along with that, you also have, along with the ST segment elevation, right? Along with the ST segment elevation, you will have PR segment depression, right? PR segment depression. This will be the ECG in case of acute pericarditis, right? I'll repeat this again. You will have ST elevation in all the leads except AVR. In AVR, you have ST segment depression and PR segment will be depressed. PR segment will be depressed. Okay, that is what you will see in the acute pericarditis. Now, you take the next option. What is that? Lateral wall MI. In lateral wall MI, you will have ST elevation. You will have ST elevation in lead 1, AVL, V5 and V6. 1 AVL, V5, V6, ST elevation. That is suggestive of lateral wall MI. That is suggestive of lateral wall MI. Okay. Next. What is the next one? Anterior wall MI. In anterior wall MI, you will have ST elevation in V1 to V4. V1 to V4. Okay. Then your Fifth option is completely wrong. Non-cardiac cause for the patient's symptoms is completely wrong. That is not the correct answer. So the correct answer here in this patient is posterior wall MI. Now, can anyone tell me which coronary artery is blocked in this patient? Sometimes they can ask you, by giving the ECG, they will ask you which particular coronary artery is blocked. Can anyone tell me this? So basically, right coronary artery. Right coronary artery, not LAD, not LAD. Right coronary artery is blocked. Right coronary artery is blocked. Okay. Now lateral wall MI. In lateral wall MI, the vessel that will be blocked is left circumflex artery. Left circumflex artery. In anterior wall MI, the vessel which is blocked is left anterior descending artery. In inferior wall MI, the vessel that will be blocked is right coronary artery. Right, in inferior wall MI, the vessel that will be blocked is the right coronary artery. So depending upon which wall you have MI, you should be able to make out which vessel is blocked. Right, which vessel is blocked. Okay, right. So whereas you take in acute pericarditis, can anyone tell me what is the etiology of acute pericarditis? What is the etiology of acute pericarditis? Yes. Avinash, whatever you are saying is correct. Posterior interventricular artery only. But posterior interventricular artery is a branch of what? Posterior interventricular artery is a branch of right coronary artery. Right? Yeah. So acute pericarditis, it is most commonly it is secondary to viral infection. Most commonly it is secondary to viral infection. Yes, Avinash, is your doubt cleared? Posterior interventricular artery? It's a branch of right coronary artery. Okay, right. So with this, I will just wind up this particular session. I hope I have discussed very important questions. Right? And tomorrow again at 7 p.m. we will reassemble back to discuss some more. Yeah. So tomorrow again at 7 p.m. Okay. So please spread the information to your friends also. Let everyone take the advantage of these sessions. Right. So ultimately, what is our goal? Our goal is that everyone should clear the FMGE exam. Everyone should clear the FMGE exam. Okay. Everyone should be very happy. Right. Please don't face the same trauma what you have faced on August 31st. August 31st was really a big nightmare to all the FMGE students. Right. So please inform to everyone, let everyone take the advantage of this session, right? Okay. So thank you very much and see you in the upcoming sessions, that is tomorrow 7 p.m.